Hello, my name is Sanjay Sharma, and I will be speaking to you today about investigating survivors of sudden cardiac arrest without significant coronary artery disease. Each year, around 30,000 people in the United Kingdom suffer an out-of-hospital cardiac arrest, which is usually due to a diverse spectrum of diseases and circumstances. However, 65% of all individuals have a primary cardiac etiology, of which ischemic heart disease constitutes 77%. The other 16% are due to cardiomyopathies and primary arrhythmia syndromes, and the remainder are due to a diverse spectrum of cardiac abnormalities, some of which are mentioned here. The situation is different in young individuals aged between 1 and 35 who have a lower burden of risk factors for atherosclerosis, but even in these individuals, this study from Australia and New Zealand shows that 25% of all deaths are due to coronary artery disease. An important 16% are due to cardiomyopathies. But interestingly, in around 40% of cases, no obvious cause of death is identified. In our experience at St George's Hospital, many of these deaths, where the heart is structurally and microscopically normal, are due to primary or genetic arrhythmia syndromes. Here is our experience on assessing the relatives of 303 victims of sudden arrhythmic death syndrome. I should define this. Sudden arrhythmic death syndrome is a situation whereby there is a sudden death where the heart is structurally and microscopically normal and a subsequent toxicology screen is negative. From these 303 victims of sudden arrhythmic death syndrome, we contacted 911 first-degree relatives, and we investigated them comprehensively for cardiomyopathies and primary arrhythmia syndromes. We found quite a high diagnostic yield of primary arrhythmia syndromes and a smaller yield of cardiomyopathies. Specifically, we found an underlying cause, usually a primary arrhythmia syndrome, in 42% of families of victims of sudden arrhythmia syndrome, of which 70% of the diagnostic yield was due to Brugada syndrome, and a smaller number to long QT syndrome, and an even smaller number to catecholaminergic polymorphic ventricular tachycardia. This is our algorithm of investigating individuals who have survived a sudden cardiac arrest in whom coronary artery disease has been excluded. We start with physical examination and history. The personal history is very important because it describes preceding cardiac symptoms. The family history is relevant because many conditions that cause sudden death in young individuals are hereditary. The ECG is very useful and is something that really needs to be looked at very carefully because it will show up ion channel diseases such as the Brugada syndrome, which is characterized by an RSR pattern in lead 1 followed by a coved ST segment and a negative terminal T wave. Here is someone with long QT syndrome. Long QT syndrome deaths usually occur during physical activity or during adrenergic stimuli such as anxiety or being alarmed, but some deaths, particularly those due to long QT syndrome type 3, may also occur in sleep. Here is an example of someone with Wolff-Parkinson-White syndrome showing a short PR interval and a slurred upstroke to the QRS complex, typical of this accessory pathway, which may cause SVT but also atrial fibrillation that could degenerate into ventricular fibrillation. Sometimes the ECG may show findings that are not typical of Brugada syndrome but suspicious of Brugada syndrome. In such cases, we can do a sodium channel blocker test to unmask the Brugada syndrome. Here's a typical example. Just look at lead V2, where there is an RSR pattern with a concave ST segment that is suggestive of the type 2 Brugada ECG pattern. In these individuals, we can either do an adrenaline provocation test straight away, or we can repeat the ECG by placing leads V1 and V2 in the second or third intercostal space, which increases the diagnostic yield of Brugada syndrome by 2.5-fold. So here's your conventional lead placement, which doesn't show very much. And when we place these leads in V2 or V3, in intercostal space, in the second or third intercostal spaces, we find the typical Brugada ECG pattern. We then proceed to an echocardiogram, which is important to check for structural heart disease, and this may demonstrate features of hypertrophic cardiomyopathy, dilated cardiomyopathy, left ventricular non-compaction, or even arrhythmogenic cardiomyopathy. In many instances, the echocardiogram is normal, even though the ECG is very abnormal, and in these situations we proceed to performing an MRI scan. So the sort of ECG changes that cause concern are T-wave inversion, ST segment depression, left ventricular hypertrophy with ST segment depression, Q waves, small limb lead complexes, or left bundle branch block. If the echocardiogram is normal, we do an MRI scan to look for atypical forms of hypertrophic cardiomyopathy, arrhythmogenic cardiomyopathy with left ventricular scar, idiopathic left ventricular scar, or even features of myocarditis. Here's a typical example of a young individual who suffered a sudden cardiac death in whom the echocardiogram was normal. This ECG is clearly abnormal and shows widespread T-wave inversion in leads V1, V2, V3, V4. There is a delayed upstroke to the S-wave in V2, which is a finding that we notice in individuals with arrhythmogenic right ventricular cardiomyopathy. There is also evidence of an epsilon wave, which is a positive deflection at the end of the QRS complex, and the limb leads have low amplitudes. This patient had arrhythmogenic cardiomyopathy, which was diagnosed after subsequent investigation, even though the echocardiogram was normal. The exercise stress test is also useful and should be performed in all young individuals who have survived a sudden cardiac arrest, because it can unmask the Brugada ECG pattern, especially in early recovery. It can demonstrate paradoxical prolongation of the QT interval during exercise. It may provoke ventricular tachycardia or unmask catecholaminergic polymorphic VT. Here's an exercise stress test in someone who had Brugada syndrome. You will see that as this individual reaches peak exercise and then starts to recover, there is this marked ST segment elevation, which is noticed best in leads V2 that you see at the beginning of recovery. And our theory is that immediately after exercise, intensive exercise, there is vagotonia, and this vagotonia may unmask the Brugada ECG. Here is an individual who's having an exercise stress test. This is an individual with long QT syndrome. Our practice is to perform an exercise stress test where we do very frequent ECGs between the baseline heart rate and a heart rate of 120 beats per minute. With increasing heart rate, the QT should shorten, but in individuals with long QT1 and to some extent long QT2, there is paradoxical prolongation of the QT interval as shown here, which is highly suggestive of long QT syndrome. Sometimes the exercise stress test will show up this phenomenon, which is bidirectional VT, that is so characteristic of catecholaminergic polymorphic VT. In general, we don't actually see this typical ECG pattern, but we normally see multiple ventricular extrasystoles arising from various sites. Here's an individual whose brother died suddenly from arrhythmogenic cardiomyopathy. This is his ECG, which is not showing too much, but during an exercise stress test, we provoked VT very quickly, and the subsequent MRI scan made the diagnosis. Sometimes, despite all the conventional tests, including MRI, we don't find anything wrong. In these situations, especially if someone's died during sleep or at rest, which is so typical of Brugada syndrome, we proceed to a sodium ion channel blocking or sodium ion channel provocation test. Here you've got an adrenaline provocation test. Adrenaline is a sodium ion channel blocker, and here we've got leads V1 and V2 placed in the fourth intercostal space. These are the conventional positions, plus also in the third and second intercostal space. And you will see that after adrenaline, we provoke or reveal this typical Brugada syndrome, and you can see that this ECG pattern is seen best in the third intercostal space in this particular situation. I should finish by just emphasizing that these are rare conditions, and therefore investigation should be performed in a specialist clinic where there is rapid access to all non-invasive cardiac tests, including CMR. There should be facility to perform pharmacological provocation tests. Because this affects a whole family, they should be linked with a pediatric cardiologist because children are also involved. We often need to implant defibrillators or ablate accessory pathways, and hence the link with an electrophysiologist. Given the genetic nature of these conditions, the association with a geneticist is very important. And I cannot overemphasize the importance of good pathology, because it's the actual pathology in someone who's already died that gives us the correct diagnosis to look for in surviving relatives. So in conclusion, out-of-hospital cardiac arrest is due to a diverse spectrum of cardiac and non-cardiac diseases. A primary cardiac cause is identified in approximately 70% of cases. Ischemic heart disease is the leading cause in such cases. Inherited primary arrhythmia syndromes and cardiomyopathies are important causes of cardiac arrest, particularly in the young. Comprehensive evaluation in a specialist cardiac centre is essential because such diseases require lifelong surveillance and risk stratification and affect entire family units. Thank you very much for your attention.